This is one of my first movement disorder patients. This was her appearance when she first appeared in my office. These are photos of her occlusion. The top photo gives you the amount of overbite that she has when she occludes her teeth together. This, to me, is a very deep bite. I do not want to see the upper incisors overlapping more than 20% of the distance of the lower incisors. In fact, I prefer less than that. On the lower left-hand side, she has a class 1 occlusion, and on your lower right-hand side, she has a class 2 occlusion. These are measurements of her range of motion. You can see that she has a 35 millimeter interincisal opening. This would lead you to believe that she has a unilateral or bilateral closed lock. However, you'll notice that she has a left click at 21 millimeters of opening and a right click at 25 millimeters of opening. This shows you that you cannot depend on clicking joints to determine whether they're reducing or non-reducing, because even closed lock joints, which this is a case, click too. The significant history that this patient gives was that she fell in an icy parking lot that was not sanded or salted, and there is a lawsuit involved. She has worn 2 hard upper plastic maxillary splints that she says did her no good. I have never used a maxillary upper splint. I cannot understand why other people use them. They say they stabilize the situation or stabilize the occlusion, but what they are really doing is stabilizing the disc out of place in its current position so it never does improve. She now wears a soft maxillary splint that makes my face sore. The professional literature shows that these soft, suck-down rubber-type splints cause increased muscle spasm, and I would not recommend using one. She was 1 month late being born. This is an indication of birth trauma, and her mother describes her face as being all torn up when she was born. She has inability to walk, and this was her big movement disorder. She's a newly married young lady, and she and her husband went out and bought a townhouse, and she can't navigate the stairs. She must crawl up the stairs of her townhouse due to severe vertigo. These are the tomographs of her left and right temporomandibular joints in centric occlusion. You can see at the bottom of the x-rays the teeth are together. And we use these films to evaluate the position of the condyle in the fossa, whether the condyle is anterior of center, posterior of center, or superiorized, inferiorized, etc. These are tomographs of the left and right temporomandibular joint in the mouth wide open position. You'll notice the condyle does not travel sufficiently on the left tomograph. It is supposed to travel past the eminence and be separated from it by 2 to 2.5 millimeters of space, which is the thickness of the disc. If one bone, the condyle, is touching the other bone, the eminence, you know there cannot be any disc interposed in between. The one on the right shows the 2.5 millimeter space occupied by the disc, which is in place in the wide open position on the right side. This is the patient that has been wearing the splint for approximately 2 years or so. She dropped out of my practice, and you can see that the splint has been added to by several layers, particularly on the left side. This is the patient occluding on the splint on the right side and occluding on the splint on the left side. She is asymptomatic and fully functional. When the splint is taken out of the mouth, this is her occlusion. She has a severe posterior open bite. This would really disturb most dentists that look at it because they do not know how to correct an open bite in the posterior. This is her occluding on the left side. Believe it or not, the discs are in place on both sides, and this is her true centric relation position, even though she has a posterior open bite. If you have done your job right, and the patient presented with their teeth together in the back, and you have fixed the problem, you will always, always, always have a posterior open bite. If you do not, you have not fixed the problem. Because in the treatment, you want the condyle to be inferiorized and a disc to go back on top of the condyle, and all of that requires space. And that's the reason for the posterior open bite. Now, believe it or not, this case is 75 or 80% done. You can look at this slide and you can see that not only are the discs in centric relation, but the midline is corrected, the overbite is corrected, the overjet is corrected, and all we have to do is make the little white things on the bottom touch the bigger white things on the top, and the case will be finished. These are the steps to treat this case. You have to tripod the occlusion front and back, either with second molar buildups or with a removable appliance, because you don't want the patient to overclose or to lose the treatment position that you have worked so hard to obtain. Then at the same appointment, bond or band, whatever you do, the maxillary arch and level and align it. Keep wearing the lower appliance at the same time. You insert a maxillary expansion appliance because the mandible has been moved forward, and you must expand the maxilla to accommodate an advanced mandible, or else the teeth go into crossbite in the buccal segments. Then when you're ready, you bond or band the lower arch, level and align them, and use extrusion mechanics to lift up the teeth in the lower buccal segments. This is the incisor buildups being applied to the maxillary central incisors. These are bonding material is used here to make lingual shells. This is what it looks like when the bonding material is applied, and you can make these either flat or hollow ground them so the lower teeth fit into them like a keyway, or you can make them on a slanting upwards and forwards, so that when the lower teeth hits them, you have built in an anteriorizing interference. This is the expansion appliance that we used on this patient. The anterior and posterior expansion screws will expand the maxilla transversely. The left and right expansion screws will expand the maxilla anteroposteriorly. Another way to do this is to activate all 4 screws simultaneously and just expand out the maxilla at one time. This is what I usually do. This is what the maxillary expansion appliance looks like from the side. You can see the screws have been expanded at the top of the appliance for a considerable amount of time. You can see where it is tripoded in the posterior with these extensions that extend inferiorly, occluding on the lower second molars. This is the upper appliance seated in the roof of the mouth. You can see how it is festooned around the maxillary buildups, and the brackets have been placed on the teeth, and all of this has been done in one appointment. This is what it looks like at this time from the front, before we have put in the initial arch wires to approximate the teeth. The maxillary appliance is in. You can see the extensions in the left and right background, and it is maintaining our treatment position. Now, the question should arise in your mind is, where do you establish the occlusal plane in the new treatment position? In other words, in this new maxillomandibular relationship, where are you going to occlude the teeth? There are 3 positions that are usually accepted. One is halfway between the occlusal surfaces of the incisors and the molars on the upper and lower arches. This is the edgewise technique, where you would extrude the upper teeth halfway down and extrude the lower teeth halfway up, and they would meet in the middle. The second technique would be to intrude the lower incisors all the way down to the level of the occlusal plane of the second bicuspid and first molars, using utility arch wires. This is the bioprogressive technique popularized by Robert Ricketts. The technique I use is a constructed occlusal plane at the incisal edges of the lower mandibular incisors extending posteriorly without a curvus spee. In other words, I have this imaginary occlusal plane in my mind and I extrude all the lower teeth up to it on each appointment. This gives maximum support to the overlying temporomandibular joints. This is a drawing of what it usually appears like when the patient presents for treatment initially in his initial symptomatic habitual occlusion with the one or both discs out of place. The treatment position ends up looking like this. The mandible is advanced. It is in an ideal position with the upper incisors, and there is a left and right posterior open bite. The edgewise technique of putting the occlusal plane halfway between the upper and lower occlusions is illustrated in this drawing. The bioprogressive technique of using the occlusal plane of the lower first molar and the second bicuspid as a true occlusal plane and correcting everything down to this level is what the bioprogressive people use. What I use is an imaginary occlusal plane from the incisal edge of the lower incisors extending all the way back through the second molar without a curvus spee, and I elevate all the teeth in the lower buccal segments up to this occlusal plane. And this is what we're going to be doing on this patient. I'm going to show you how to do it with just 5 arch wires in this case. The initial arch wire is a lower twistiflex wire that is very flexible and goes through all the teeth. Nowadays we would use a titanium arch wire or a nickel titanium arch wire to do this. The second wire is an 016 multi-loop stainless steel wire, the multi-loops providing flexibility of the arch wire and making it more gentle. Make sure the horizontal portion of the boot loops are extending towards the depressed teeth. This gives you maximum mechanical advantage. This is the same wire from the front. This is the next wire on the lower arch without the loops. It is a continuous stainless steel arch wire, and you can see it from both sides with the maxillary expansion appliance in place. What we are doing is closing the spaces now with elastic thread. The teeth are touching each other, and you can see they are doing so without over-rotating or over-closing the mandible because the overbite is not increasing. In fact, the overbite is 0, edge to edge, and the teeth are in contact on the buccal segments. This is it from the left side, which is the 4th arch wire, which is a 1616 stainless steel arch wire on both the upper and the lower. This is the case debanded, and you can see that the teeth in the lower buccal segments are in contact. The teeth themselves have been extruded. The alveolar tissue has been extruded. The crestal bone has been extruded. And all of it comes up together if you do this properly. This is it from the right side in centric occlusion. And this is the right side with cuspid guidance showing you that there is disclusion of the teeth. This is a composite of the right side showing centric occlusion on the upper left and cuspid guidance on the lower right. This is centric occlusion on the left side showing good interdigitation of the teeth and cuspid disclusion on the left side. This is a composite showing both the centric occlusion on the upper left corner and cuspid disclusion on the lower right corner. This is the before and after, and it probably took about 18 months to go from the before picture on your left to the after picture on your right. This is the right side. This is the left side showing her when we started, stage 2, and centric occlusion on the right side. And again, I want to emphasize this only took 5 arch wires and approximately 18 months in time. This is centric occlusion on the top photo in both centric occlusion and centric relation. And this is the protrusive excursion on the bottom slide. This was her before treatment when she started, and you can see the amount of overbite correction comparing the upper photo to the lower photo. This is the patient. In other words, we not only straighten their teeth, but we reconstitute their whole wellness. You can see how she was on the left, and if you don't realize this is a sick patient with an internal derangement, you will correct her teeth to the internal derangement. But if you correct the internal derangement first and make her fully functional and asymptomatic, you get the patient on the right. And then if you interdigitate the teeth right and stabilize her in this condition, you have set her up for the rest of her life. This is her showing the amount of interincisal function she has at the end of treatment. We want 48 to 52 millimeters interincisally on an adult, and if it happens to be a child, 54 millimeters. Do not think of children as little adults who can't do things as good. Think of children as people with shallower glenoid fossils, looser ligaments, looser capsules that can do things in excess of an adult.